Valley, which is always a challenge, but I'll do my best. So my task is, and oh, here it is to discuss the data that we have on PD-1 and PD-L1 inhibitors as frontline agents in advanced non-small cell lung cancer. Um, I noticed that it stops at conflicts. It's interesting. Anyway, so my what I'm hoping to do is discuss the sort of the background to using these drugs in frontline therapy, discuss the data with at least these three agents. This is the data that I'm aware of. I'm sure with the other agents in this class, there might be frontline data that I'm not aware of. And then as we go along, discuss some of the ongoing trials. So the reason that these drugs have generated excitement, as Dr. Carbone mentioned, is not just because of the response rate of 20% in the recurrent setting, but the fact that this benefit is sustained. This is data from 017, and at the point of data analysis, 63% of the patients who had responded had continued benefit, as opposed to 33% in the patients with docetaxel that were treated with docetaxel who had a response. And this desire for sustained benefit that has generated an interest in looking at these agents in the frontline setting. Now, we do have data of using these agents as frontline therapy in a different tumor type of melanoma. This was from the New England Journal paper this year that randomized patients to Nivo alone, Nivo plus ipilimumab versus the standard of care at the time of start of treatment of ipilimumab alone. And both the experimental arms, that is Nivo alone and Nivo plus ipilimumab, showed an improvement in the co-primary endpoints of progression-free survival and overall survival compared to EP alone. But what was interesting is when one looked at the specific subgroups, that is the PD-L1 positive patients, the benefit with Nivo alone was as much as what was seen with Nivo plus ipilimumab, suggesting that in a group of patients, adding the ipilimumab to Nivo alone did not provide any additional benefit. And it was only in the PD-L1 negative patients that the combination was better than Nivo alone. Again, this was a secondary endpoint. And I'm sure Dr. Carbone is cringing even more that I'm using a completely different tumor type to compare, much more different than the GIST versus EGFR mutation positive patients. But the only point I wanted to make was that Nivo alone or PD-1, PD-L1 inhibitors alone could provide significant and durable benefit as frontline agents, even in advanced non-small cell lung cancer. And it is this promise that has generated interest as for the first line agent. So what data do we have? This is data from Checkmate 012. This was looking at Nivo as single agent versus variety of combinations as frontline therapy in advanced non-small cell lung cancer patient. The data on Nivo alone was as frontline agent was presented by Dr. Scott Gettinger at this year's ASCO. There were a total of 52 patients that were enrolled. 75% of the patients had non-squamous histology. About 80% were current or former smokers. I suspect, and though I was not sure from the poster, but I suspect that these EGFR mutation patients were treated after EGFR TKI, and about 17% of the patients were KRAS mutation positive, though in a substantial number of patients, the KRAS status was not known. So this is the efficacy data in these patients. So overall, about a 23% response rate, similar responses between squamous and non-squamous. So the numbers are different. But if you look at the median duration of response, and that's what I mean, that it's not the sort of just the response rate, but the patients who do respond, it's the sustained benefit that is very encouraging. And so you see the median duration of response at a median follow-up of 63 weeks, it had not been reached, and promising PFS and median overall survival rates. Now, they did look at PD-L1 assessment and efficacy, and this was discussed in the previous presentation. And they looked at several cutoffs. I'm just showing the two extremes. So they looked at 50% versus less than 50% expression, and this is the assay that they used. And 26% of these 52 patients had PD-L1 positivity at greater than 50%. And in these 26% of the patients, that is in these 12 patients, the response rate was 50%, lower in the patients who had less than 50% expression, and similar difference when you use 1% cutoff. If you use 1% cutoff, 70% of the patients met the criteria, and the response rate was 28%. But again, suggesting if you have any PD-L1 expression, the response rate is better as compared to lower PD-L1 expression. As Dr. Carbone mentioned, interestingly, when they looked at smoking history, the activity, if you just looked at smoking as the current or former smokers, the response rate was similar to what was seen if you looked at 1% cutoff. So smoking history does predict for at least response rate, though they did not present data as to the duration of response and other efficacy criteria. So their conclusion was that it does provide durable benefit, at least in a proportion of patients. PD-L1 expression did appear to predict for benefit, but it is important to note that responses, though lower, were seen in patients with tumors that did not express PD-L1. And based on this study, as was mentioned earlier, a phase 3 study is ongoing, which is randomizing patients to Nivo or investigator's choice chemotherapy in frontline setting based on PD-L1 expression. There's another frontline study ongoing, and this is not based on PD-L1 expression, though PD-L1 expression will be assessed. And in these patients, patients are randomized to Nivo alone or the combination of Nivo plus ipilimumab or a platinum-based chemotherapy based on histology. And both these studies, the primary endpoints are overall survival with co-primary endpoint of progression-free survival. Coming to the pembrolizumab data, and Dr. Carbone mentioned this study. This led to the approval of pembrolizumab in recurrent setting. However, this study did evaluate pembrolizumab in treatment-naive patients, and there were a total of 101 patients in this study that were treatment-naive, and there was a response rate of 27% seen in the overall population. And like the Nivo data, if you look at PD-L1 expression, the response rate was higher. It is quite interesting that even though this is a different assay than the Nivo study, about the same percentage of patients, about 23 in the Nivo study. Now, this is a much larger number in the Pembro trial, but in the Nivo 52 patient trial, the expression of greater than 50% was about 26% of the patients. So the same, approximately similar proportion of patients have this high expression of PD-L1, and the response rate also was very similar, 50% in the Nivo trial, 50% in this Pembro trial, with lower response rates in patients with tumors that had lower PD-L1 expression. The 6-month PFS rate in these patients was 77%, again, showing the sustained benefit seen once a patient does derive benefit. And this is reflected by these bar graphs, that is at the time of data analysis among the patients who had a response rate, who were treatment naive, 100% of the patients had continued benefit. So there are, again, several Pembro frontline studies, including a single agent that have either been initiated or about to be initiated. And then looking at a PD-L1 inhibitor data of atezolizumab, this was from the Birch trial. This included patients that were treatment naive as well as patients who had had previous therapy. But the entry criteria mandated a certain level of PD-L1 expression. And as you know, in the atezo studies, they not only look at the tumor expression, but also look at the PD-L1 expression in the tumor infiltrating immune cells. And the criteria were that at least there had to be 2+ or 3+ tumor expression or immune cell expression within the tumor for the patients to enroll on the study. This is looking at all patients, but if you look at the frontline patients, there were a total of 139 patients enrolled, median age of 67. The proportion of patients that had at least 3+ tumor or immune cell expression was 47%. And if you look at benefit, the efficacy rate was similar, though there is some selection in these patients. But again, about a 20% response rate seen with Atazo, and again, patients with had higher expression of PD-L1, either in the tumor or the infiltrating immune cells, the response rate was higher. These are the overall survival rates with the median overall survival in the frontline setting of 14 months and a PFS of about 6 months. Now, as was mentioned, PD-L1 expression has been utilized in these studies, and each of these studies have shown that patients with tumors that have high PD-L1 expression have a greater benefit. However, as all of you know, these assays are different. The antibodies are different, but the frontline studies are moving forward utilizing these independent assays. And so there does need to be a uniformity if we are going to sort of move this field forward as to understand in which patients to use these agents as frontline therapy. The other problem with the assay is that patients who don't have tumors that don't have PD-L1 expression still respond to these drugs, and we wouldn't want to eliminate the benefit of utilizing these agents as frontline therapy as single agents. And so as Dr. Carbone mentioned, and I promise you I did not look at his slides before, but he showed this data of that we may have better markers, and he discussed this data much better than I can, similar to what Dr. Siebert presented last evening about maybe there's an inflammatory signature, and these sort of genomic analysis may allow us to select these patients better as to who are going to respond to these single agent therapies. So in conclusion, before I conclude, there are trials going on that are assessing these drugs in frontline therapy. I'm not mentioning all the trials. Some of the trials are looking at maintenance therapy apart from using it as frontline treatment. There's an interesting trial going on at MD Anderson that is looking at doing SBRT to one single site and then using anti-PD-1 with the hope of exploiting the abscopal effect. There's an alliance trial that is looking at the sequence of therapy in the frontline setting, starting off with chemotherapy followed by a PD-1 versus starting off with the defined cycles of PD-1 followed by chemotherapy make a difference. The adjuvant trials were discussed by Jamie, so I'm going to skip that. So in conclusion, the response rates are about 25%, similar to what was seen as in recurrent setting of these single agents. And I think what is promising about this is that with one single agent, you can have a sustained benefit for a long period of time, but only ongoing randomized trials are going to define in which patients in which patients we should be using these as single agent frontline therapy. Thank you very much.
So, by the way, the 227 trial has now been amended so that PD-L1 negative patients don't get randomized to the Nivo arm. Nivo alone. It's randomized between Ipi-Nivo and chemo for PD-L1 negatives, and PD-L1 positives, it's the 3-arm randomization. Chemo, Ipi-Nivo, and Nivo. And I argue, actually, the Alliance sequencing trial, I argued strongly against that trial because the design, it looks at 4 cycles of immunotherapy followed with a switch to chemo, regardless of how the patient is doing. So you have a great response to immunotherapy. The patient's feeling great. They have no side effects. And you're going to stop it and give chemo? I would not put patients on that.
I don't know if Dr. Wokes wants to comment on that.
I'm sorry, Everett.